So, distinguished colleagues, ladies and gentlemen, you are welcome to yet another webinar in the series of webinars organized by AFEMSON. And let me just make few remarks, because the usual thing is that most of the ESCO will be available, especially the secretary and the president. The secretary unfortunately has an emergency to attend, so he could not be available to participate in the webinar, but the president is already on the call. And you might have seen those who joined earlier that some few slides were played. And those slides are usually played and then read by the secretary. But because he will not be in attendance, just be our thoughts. But those who are opportune to have gone through it, and it's for those who have never joined the webinars. For those who have been part of it over time, I'm sure they are used to it. And for those who are members, they are also aware of all the information that the slides are displaying. So once again, you are welcome to this webinar with the title, Small Baby, Big Challenges, a Practical Guide to IUGR. I'm sure we are all going to be more enriched today by the end of the webinar. And it is going to be presented by no other person than Professor Abiodun Adeniran. And Professor Abiodun Adeniran is from the University of Ilorin. And he is an accomplished academician, and he's a fellow of the West African College of Surgeons, ONG, and the National Postgraduate College. He has a master's degree in health planning and management, as well as a doctor of medicine, MD degree, and a certificate in fetal medicine. His area of subspecialization is maternal medicine. And he has participated in many notable trials, international trials, like the MPD for QED, the Woman Trial, the IVON Trial, and the Action 1 and Action 2 trial as well. And he has published, he has served as a reviewer for a number of peer-reviewed journals, both national and international. He is a widely published academician, and he has published about 100 papers in peer-reviewed national and international journals. So you can see from the rich summary of his activities in the academia, he is an accomplished researcher as well as an erudite professor. So I would like to welcome Professor Adeniran to commence his presentation. Professor Adeniran? Professor Adeniran? Professor Adeniran?
Hello, good evening, Professor Labaran.
So you can start.
Oh, thank you so much.
The floor is yours.
Thank you.
We are going to take questions after, so you can start. Thank you.
Okay, thank you very much, Professor Labaran. Good evening to us all. I want to appreciate the AFEMSON executives, elders, and teachers on this webinar, the AFEMSON Webinar Committee members, all AFEMSON members, colleagues, and other attendees. I want to say that it's a great pleasure to be given the opportunity to make this presentation. And the title has been advertised as Small Baby, Big Challenges, a Practical Guide to IUGR. So I want to make a declaration that I have no conflict of interest, and the information provided here are from readily accessible sources and is for academic and clinical discourse. And we're going to follow this outline. We're going to take a background, look at the public health importance, the role of ultrasonography, then we go into the meat of the matter, screening, diagnosis, prevention, prognostication, and then we end with take-home points for the day. Now, by way of background, evaluation of fetal growth is one of the key objectives of prenatal care. And we all know that fetal growth depends on a number of factors ranging from maternal, fetal to uteroplacenta. However, abnormalities of these functions remain one of the commonest problems that we encounter in obstetrics practice. And the impaired fetal growth, we all know, is associated with an increased risk of perinatal mortality and morbidity, as well as long-term adverse outcome. Overall, it's been shown that growth-restricted fetuses have a higher rate of conditions associated with prematurity, and they experience worse neurodevelopmental outcome. And they are also at increases of other challenges later in life. Intrauterine growth restriction is also referred to as fetal growth restriction. Both are used synonymously. And that the primary underlying mechanisms vary, but there's a common pathway, which is usually suboptimal fetal nutrition and a suboptimal utero-placenta perfusion. Worldwide, the management of IUGR remains a complex problem. And this is basically because there are difficulties in arriving at some consensus due to differences in results, treatment options, findings all over the world. But generally speaking, worldwide, the prevalence is about 10%, ranging from 5 to 15%, depending on the population, the location. And evidence has shown that in babies that are suffering from IUGR, there's worse outcome with preterm babies with IUGR compared to those with term. And the worst outcome is in babies with IUGR that weighs less than 3% of the expected weight and also have associated Doppler abnormalities. Now, the first issue we need to look at, what's in the name? Why is it that it's been proposed that IUGR should be changed to fetal growth restriction? What's really in the name? Well, looking at this, I think one of the important things that focuses on that is that it is believed that the fetal growth restrictions focuses more on developmental origin of health diseases, and alerts also the fact that this problem is not just stopping intrauterine, something that can last throughout the lifespan of the baby. Secondly, is that FGR tends to suggest a dynamic ongoing process, unlike IUGR that it seems to be static, in that once the baby is delivered, people say it's an intrauterine problem. The fetus is outside. It's not a baby. There's no problem again, which is not true. Again, FGR tends to create in us a tendency to be more accurate in our clinical precision in the diagnosis, as well as also helping us to focus on the fetal physiology and the potential for adverse outcomes. So this is actually what is in the name. Generally, FGR tends to make it more dynamic and encourages us to see the whole picture compared to IUGR. Now, definition. Generally, IUGR is defined as inability of the fetus to reach its growth potential. And the American College of Obstetrics and Gynecology added that it can be described as a small fetus that is not fulfilling its growth potential because of an underlying pathologic condition. But there are issues, and the issues with this definition relates to those that define it based on estimated fetal weight only, those that insist on estimated fetal weight and abdominal circumference, as well as the cutoff for the percentile. Should it be the third? Should it be the fifth? Should it be the 10th? And then those that also talk about, should we use, in estimating this fetal weight, should we use a population or a customized growth chart? But generally, it is generally accepted that it can be defined as an ultrasonographic estimated fetal weight or abdominal circumference that is below the 10th percentile for that particular gestational age. And then comes the question, should abdominal circumference be a diagnostic criterion? And studies done by different people have suggested that this should be the trend in which we should go. For example, David et al. In a prospective study of 1,000 low-risk pregnancies found out that the abdominal circumference at 10 percentile have diagnostic accuracy that is similar to estimated fetal weight of 10 percentile. The same thing, Blue et al. In a meta-analysis of the reported that the abdominal circumference of less than 10 percentile actually predicted small for gestational age, as well as ultrasonographic estimated fetal weight less than 10 percentile, more than if we take the estimated fetal weight alone. And then Cardios, also in a systematic review and analysis, help us to see that actually abdominal circumference gives us a lower false positive rate, and it has a higher sensitivity compared to just using the estimated fetal weight alone. So which means that in our definition, abdominal circumference as a criterion actually has a place. This is just to look at fetal growth. We know that fetal growth has different stages. Stage 1 is the hyperplasia stage, which is in 4 to 20 weeks. Stage 2, 20 to 28 weeks, which has a combination of hyperplasia and hypertrophy, while stage 3 deals basically with hypertrophy, which is at the 28 to 40 weeks of gestation. And this becomes very important when we remember that it is at stage 3 that you have 80% of the fetal weight gain occurring. And this is when we actually have rapid accumulation of fat, muscle, and connective tissue, which we will see later as we move along. So what are the determinants of fetal growth? It could be maternal, it could be fetal, and it could be fetal-maternal as stated. But it's important to note that maternal health conditions play a very important role here, which will include hematological conditions like anemia, and especially hemoglobinopathy, which we know are not uncommon in our own environment. It's also been linked to maternal habits like smoking and drug abuse, while the placenta factor will include a problem with the uterine placenta status in terms of insufficiency. Now, what are now the assessment tools for fetal well-being? Now, this slide shows that we can have what we call the fetal growth velocity, or we can also have customized fetal growth charts. Now, the difference between the two is that customized charts take into consideration other confounding variables like maternal height, maternal weight, parity, and even the fetal sex, which we all know can have effect on the weight. But the fetal growth velocity talks about a serial charting of the estimated fetal weight, and it can also include the cervicofundal height that is used for that particular baby. So it's all about getting to understand a particular fetus better than just lumping it into the general population. And then we now have fetal velocimetry, especially Doppler. Doppler is very important. In fact, it's a key factor in both the diagnosis and monitoring of IUGR, because it can help us to evaluate what is happening both at the fetal side, the placenta bed, as well as the uterus at its fetal side also. For example, on the fetal side, Doppler velocimetry is able to help us to understand what happens with the umbilical artery as well as the middle cerebral artery when the fetus is exposed to hypoxia. And it is these that are then reflected in various definitions, especially the pulsatility index, that helps us to be able to understand how the fetus is faring. On the maternal side, the uterine artery mean pulsatility index is very important because it has been shown to be associated with placenta insufficiency as well as maternal vascular abnormalities, which affect fetal-maternal exchange. For the umbilical artery, a progressive increase in pulsatility index has been shown to connote problem with the fetus, based on inadequate supply, for which the fetus then try to compensate. These compensatory efforts can then also be discovered based on Doppler, such that we now have ominous signs on Doppler velocimetry of uterine artery, of the umbilical artery. And this will include things like either an absent or a reverse end-diastolic flow. So this is able to help us to know that the fetus is actually going from hypoxia to acidotic level. But there is a difference between the umbilical artery response and the middle cerebral artery response. Unlike the umbilical artery that responds with vasoconstriction, the middle cerebral artery responds with a vasodilatation, and that is what is called the so-called brain sparing effect. And it's a measure of what happened in the cerebral circuit due to a redistribution of the cardiac output. Again, very important for us in the assessment is the ductus venosus, which is also an assessment on the fetal side of what is happening. And we are particularly interested because it tells us about the flow towards the heart, which we know is a function of the peripheral resistance or vascular instability. So we are interested in either an absent or a reverse A wave. And this has been shown to correlate with fetal acidemia also, as well as problem with myocardial function. So biophysical profile is also important. It consists of combined evaluation of fetal tone, body movement, but much importantly is that it can give us an assessment of the acidotic state in a fetus. For example, a score of less than or equal to 4 is associated with a fetal pH of less than 7.2, while a biophysical profile score of less than 2 has a sensitivity of 100% in detecting fetal acidemia, such that when we do biophysical profile, we can then be able to say, no, this fetus is not just at the level of hypoxia, it has actually gotten to the level of acidemia. And then we have the cardiotogograph, which tends to tell us about the fetal heart rate variability and its response to the intrauterine environment. While it is good in helping us by showing us the short-term variation in the beat-to-beat fluctuation of the fetus, it has been said that a computerized CTG actually gives a better result. And that is because a computerized CTG does not only show us the tracing, it analyzes the tracing based on input software to give a result instead of the visual inspection and calculation that we have to do with the regular CTG. So computerized CTG is actually superior to the regular CTG, but CTG is one of the ways by which we can assess fetal well-being. And this was what made the International Society of Obstetrics and Gynecology to make some recommendations at this level. First, is that fetal size alone is not sufficient to identify growth restriction unless the abdominal circumference or estimated fetal weight is below the 3rd percentile. And that a drop in fetal growth velocity, especially when it is more than 2 quartile, can actually be one of the first signals to us that there can be an intrauterine growth restriction here, even before we get to the fetus being less than the 10th percentile. And that Doppler velocimetry is useful in differentiating between uteroplacenta and fetal placenta circulation. But much more important is that in assessing a fetus for intrauterine growth restriction, multimodal assessment is recommended. In other words, we do not just use the estimated fetal weight. We use estimated fetal weight, we combine it with the abdominal circumference, and then we validate this with fetal Doppler assessments. And then again, we need to also make a distinction between small for gestational age and intrauterine growth restriction. Sometimes people use this term synonymously, but it is not so. And a very good distinction will be to say that an SGA fetus will be a fetus that is constitutionally small, healthy, and not at an increased risk of adverse outcome. Whereas IUGR refers to a fetus that is small, has some measure of pathology in place, is at risk of poor perinatal outcome, and has a perinatal outcome that is worse compared to similarly normally grown fetuses. And this table is trying to show us the difference, how we can differentiate between a normally small fetus like that we fit to definition of SGA, IUGR, and other fetuses that may be small due to other reasons. Very important here is the role of amniotic fluid, which is usually reduced in placenta insufficiency, uterine artery pulsatility index, which is usually increased and is normal in the others, uterine umbilical artery pulsatility index, which is also increased, normal in the others, as well as the middle cerebral artery pulsatility index, which is reduced in IUGR, but normal in the other small fetus. So this is supposed to help us to be able to make a distinction between SGA, IUGR, and the small fetus due to other reasons like congenital abnormality. Now, what's the public health importance of IUGR? Where are we talking about it? It's important because we know that perinatal death in Nigeria remains unacceptably high despite all the efforts, and we are a major contributor to global figures. The same with our contribution of SBA babies. And SBA babies, IUGR is now a subset of SBA babies. In other words, if we are able to give attention to IUGR fetuses, we may in the long run be able to reduce mortality and other adverse outcomes from SBA babies and bring down our indices that are not favorable. However, IUGR increases risks for stillborn, and of utmost importance is the fact that if a fetus is growth restricted and it is not detected antenatally, the probability of adverse outcome is 5 times. And this is why we need to have a way of assessing this in utero. Now, in Nigeria, there has been some work on intrauterine growth restriction, but for this presentation, I brought out these two because they have some important correlates and relationship with this presentation. For example, Olusanya in Lagos found a prevalence of 4.3% of IUGR when he analyzed 2,619 babies, and he alluded to the increased adverse outcome. But Inyage et al. In Jos help us to see that the prevalence of SGA is higher than that of IUGR, which is not a surprise because that is what is expected, because IUGR is actually a subset. And to actually add to that is that most of the IUGR in their studies were from women with preeclampsia, which then tells us that we need to pay closer attention to preeclampsia prevention and management. And they also help us to confirm that umbilical artery Doppler velocimetry, which has been proven to be useful in other countries, is also useful in Nigeria in 89.3% of the IUGR cases. Now, what's now the role of ultrasonography? In the management of IUGR, ultrasonography is important first in measuring fetal biometry, because IUGR is all about growth, and fetal biometry is what helps us to be able to follow the growth pattern of a particular fetus. It is also this fetal biometry that helps us to be able to estimate the fetal weight of the fetus to be able to arrive at our diagnosis of IUGR. And then comes the other importance of ultrasonography, which is the Doppler studies, which helps us in the diagnosis because of the abnormal Doppler. It helps us in the categorization, and it also, much more importantly, helps us in the monitoring of these fetuses. So we can see that ultrasonography plays a key role both at the level of fetal biometry and advanced studies, that is Doppler studies, in the management of IUGR. Now, important in IUGR is the estimation of fetal weight. And a lot has been written about this in the literature. We input the data, we get the abdominal circumference, we get the biparietal diameter, and then the ultrasound works the calculation and gives us. But there have been some issues that we need to look at. For examples, the NICHD and the WHO's studies actually help us to know that we need to pay close attention to racial and ethnic differences when you are looking at fetal growth. While the Intergrowth 21st formula tried to give us a different formula for calculating the estimated fetal weight, but it has been found that it does not perform as well as the more population-based and widely used HADLOC when it comes to estimating fetal weight of babies greater than 28 weeks, such that HADLOC formula was found to be better and more sensitive when we compare it to these other new formula that are being brought forward. What does this mean? What this suggests then is the fact that the HADLOC formula, which is popularly used, is actually a good predictor, and it predicts SGA and by extension IUGR better than many of these new formulas that are coming up, and it can actually be used and is readily available even in our own environment. Again, we also need to know that in calculating the estimated fetal weight, multiple parameters must be used. It is not advisable to use a formula that uses one parameter. And the difference is because a composite estimated fetal weight calculation based on these reference charts will give us a better estimated fetal weight that will give us a more accurate data. Again, it's also found out that ultrasonography also helps us to also identify fetuses that are with severe IUGR, that is those that are less than 3% of the third percentile of the expected fetal weight. So what is now the role of healthcare workers? The role of healthcare workers include the fact that we should use standard planes for our acquisition of data. So correct caliper placement is very, very important. Secondly, we should also try to imbibe the habit of quality control by keeping images and measurements for review later, so as to be a way of helping us to ensure quality assurance. And thirdly, is the fact that the reference charts that we use must be those that use multiple parameters for arriving at the estimated fetal weight. And this is just trying to help us that when you want to check the head circumference correct plane, you must see the cavum, septum, pellucidum, as well as the thalamus, and then the correct plane as against the biparietal diameter. While doing abdominal circumference, we need to see the gastric shadow as well as see the umbilical vein, so that we'll be sure that we are in the correct plane. So what's now about, let's now go on to the issue of management. Now, the first thing in management of IUGR is screening. Now, why do we need to screen? We need to screen because IUGR occur mostly in the general population. In other words, many women whose fetuses we have IUGR may not even fall into any of the risk categorization that we may have. Secondly, is that early diagnosis and adequate follow-up usually improves outcome. But in doing this, the RCOG has come up with some recommendations. First, the RCOG recommends that all women should be screened at 14 weeks of gestation, but they raise some issues. First, is that we need to do an assessment of the a priori risk. Now, what do you mean by a priori risk? This talk about the probability that a woman is going to have a complication, pregnancy complication she's having in the index pregnancy based on what happened in previous pregnancy. Concerning the assessment of a priori risk, we may have some challenges in this environment because of poor data collection. And that is to help us to know that correct data collection and documentation is very, very important. Then the RCOG also raises issues. So what's the effect of absence of risk factors Or if a woman has a multiple risks, how does that affect the risk in index pregnancy? And then the fact that most screening tools are risk checklists, where we just tick yes or no. And we all know that yes or no does not usually give the best answer. So the outcome of all of this is that relative to management of IUGR, we are still lacking a specific predictive model algorithm. And that one of the things we need to focus for future research is the development of a specific predictive model algorithm for IUGR. So what are the tools that we require in screening? First, IUGR is all about dating. So we must have a way of assessing correct dating. And this can be through a first trimester ultrasound, especially the one that use crown rump length, this is what has been advocated. And this further corroborates the need for an early dating ultrasound in the first trimester. And the need to inculcate this as part of our culture in our obstetric practice. And then we need a history. We talk about the risk factors. Now, physical examination, the routine semicircumferential height has been shown to have a place. And generally, it's been said that a lag of more than 4 centimeters or more can actually be suggestive of IUGR. But we should be careful of confounding variables like obesity and coexisting uterine fibroid. Also, fetal biochemical analysis is also very important. And inhibin A and after fetal protein have been chosen to be of importance in this particular regard. So, what are the recommendations? One, the recommendations are that currently there is no accurate predictive test. So we use a combination of tests, a combination of screening modalities. Secondly, is that ultrasound screening is not encouraged in low-risk population, routine ultrasound screening. What that means is that while you use your ultrasound for fetal biometry, it's not encouraged that you start doing Doppler ultrasonography for every fetus if there is no indication. And that randomized control trials do not support the sole use of semicircumferential height in screening women for intrauterine growth restriction. Now, this is a chart that is trying to tell us, the other time I talked about a customized growth chart. This is actually the customized growth chart. That is the gestational related optimal weight software. The main advantage here is that this growth chart, instead of using semicircumferential height alone or ultrasound assessment alone, has a combination of factors, which include the dating, the semicircumferential height. It also has a place for the ultrasound estimated fetal weight, maternal height, and other maternal biometry that can affect the weight, such that at the end of the day, it can increase the sensitivity of the detection of IUGR by giving us an estimated fetal weight that is objective and not subjective like many of the other methods, especially semicircumferential height. Now, the role of clinical evaluation still in screening. There are still controversies over methods of antenatal screening, but abdominal palpation, just as has been said before, can be used, but that is at a very, very low level. A systematic review actually shows that the sensitivity ranges from 0.27 to 0.76, which is quite poor, something that ranges from 27 to 76%. It means that the margin of error is quite high. And that is why it is not encouraged to use semicircumferential height alone, but it must be used with other parameters. What are now the risk factors for IUGR? This becomes very important because in risk classification, we will need this. Maternal risk factor will include maternal age, especially the extremes, previous delivery of an IUGR baby, increasing the risk by 25% in index pregnancy. And if a woman has delivered a previous SGA baby, it increases our risk threefold of having a baby with IUGR in index pregnancy. Very important is low pre-pregnancy weight, as well as low weight gain in pregnancy. And that's where our weight measurement at antenatal clinic and all of that comes in, before we then look at medical conditions like preeclampsia and the rest. Placental factors will include placenta insufficiency, which is responsible for 30% of cases. And then we have reduction in placenta size or volume, as well as placenta accidents like previa, placenta abnormalities like single artery in the umbilicus. Then we go to genetic factors, chromosomal abnormalities, congenital factors, and some other genetic factors have also been implicated. But it's very important to the Saving Babies Life Care Bundle version 3 help us to clarify the definition of IUGR in a previous pregnancy as a risk factor. And they say that it should be defined as birth weight below the third centile in a previous pregnancy, or early onset preeclampsia necessitating preterm birth in a previous pregnancy, even if you do not have access to the ultrasound finding, or if a woman had to deliver or had IUGR that started less than 34 weeks in a previous pregnancy. But in the index pregnancy, it focuses on estimated fetal weight, as has been earlier explained, as well as abnormal Doppler velocimetry. And this will include uterine artery Doppler, as well as umbilical artery Doppler. Now, after we have screened the woman, the next thing will be, we have screened with all of the screening tools, then we confirm our diagnosis with Doppler ultrasonography. The next thing is to categorize the woman. And this is also very important in management, as we'll see later. Now, categorization can be based on anthropometric parameters. This is what gives us the type 1, type 2, type 3. That is the symmetric, the asymmetric, and the mixed IUGR that we are all used to, with all these as their various characteristics. Another way of categorization is based on the time of onset or diagnosis of this IUGR. And this helps us to categorize into early IUGR, where it occurs less than 32 weeks of gestation, which is typically more severe because it connotes a baseline problem in the fetus or the placenta or the mother. And usually also early IUGR also shows us that in such fetuses, we need to look out for systemic adaptation to peripheral vasoconstriction due to chronic hypoxia. And they are the ones that show us the typical Doppler deterioration that we see in the umbilical artery, ductus venosus, as well as what we see in the biophysical profile. Early IUGR is usually associated with higher mortality. And in early IUGR, the major challenge is the management, as we are going to see later, because there are different suggestions on the management. For late IUGR, it is the commoner. 70 to 80% occurs after 32%. It's less associated with maternal hypertensive disorders. Hypoxia is less. So we are not going to see the typical cardiovascular system adaptation that we see in early IUGR. And the major challenge in late IUGR is the issue of diagnosis. But there are diagnostic criteria, as we're going to see later, which have been agreed upon. Now, this table is showing the main clinical characteristics of early and late onset IUGR, just as has been said. But important to know that in late onset IUGR, the fetus may not necessarily be very small. So when you do ultrasonography, actually, they may actually fall between 10 and 90% percentile of the estimated fetal weight. But we are going to see other abnormalities like abnormal Doppler velocimetry. And this is what further confirms the fact that we cannot use estimated fetal weight alone for diagnosis of IUGR. It can be made, it is used for the definition, but in the diagnosis, we actually need fetal Doppler velocimetry. Now, this table is showing us the consensus This is a consensus-based definition for early and late fetal growth restriction. And what is important here is the fact that we can see, just as been shown before, that the early dwells more on abnormalities of vessels, vascular abnormalities, uterine artery pulsatility index greater than 95th centile, or umbilical artery pulsatility index that is greater than 95 centile. Whereas for late IUGR, that one dwells more on the size of the fetus, the abdominal circumference or estimated fetal weight of less than 10 centile, as well as the cerebroplacental ratio. Now, why this is important is because the cerebroplacental ratio tells us the ratio is the ratio of the pulsatility index in the middle cerebral artery compared to that one of the uterine artery, which helps to let us know that this is actually occurring late and can help us to distinguish between early and late. Because as we know, in late, the middle cerebral artery velocimetry shows vasodilatation, unlike vasoconstriction that we have in the umbilical artery. This is actually a consensus. It's been agreed upon. Now, there are other methods, and other methods include angiogenic markers, placenta growth factor, soluble FMS-like tyrosine kinase, or the ratio between the two is now clinically available and recommended for diagnosis of preeclampsia in some countries. But it is also a potential biomarker because it does not only predict preeclampsia, it primarily shows or suggests abnormality of the fetal placenta milieu, which we know is a major factor when it comes to intrauterine growth restriction. So it has been used for that. However, according to the Royal College of other biomarkers that are also being used are human placenta lactogen, estriol, placenta growth factor, and all the rest of them. But it is important to know that these biomarkers have shown promise in the ability to improve diagnosis accuracy of ultrasound when we combine fetal markers together with ultrasound findings. However, it is not recommended for non-hypertensive women. And the reason is because in such women, they may not have the early signs of fetal placenta abnormality, uteroplacenta abnormality that we see in preeclampsia. And that is one of the challenges or caution that we need to put in mind when we are using these angiogenic markers. Now, after we have made a diagnosis, we need to now do risk stratification. Now, this risk stratification is from the Northwest Regional Guidance in the UK, and actually that is what they use. So we need to also be aware of that. And they classify women into low risk, moderate risk, or high risk for IUGR based on the findings. But we will see that for the high risk, that is where they actually brought in the biochemical parameters to help us to actually further see the importance of biochemical parameters, especially in IUGR prediction and in determination of the outcome, because they have been associated with poorer outcome. On risk assessment, the Royal College of Obstetrics and Gynecology recommends that all women should be assessed at 14 weeks, that we should also assess the birth weight, gestational age, birth centers of all previous pregnancies. We should take note of previous IUGR, previous stillbirth, previous miscarriages, as well as medical conditions, and that all these should be used in arriving at a final risk categorization of the particular woman. Now, some interventions have also been used in the antepartum period. People have talked about nutritional and dietary supplements or bed rest. Now, the truth about this is that there is no consistent evidence, because we kept having some that shows that they are useful, while others shows that they are not of significant benefit. Then come the low-dose aspirin. Now, low-dose aspirin is very important because we know that it has been shown in preeclampsia that it helps to modulate the abnormalities of the at the placenta bed. The recommendation is that we should use low-dose aspirin for women who has had previous preeclampsia, previous baby that weigh less than third centile, or if in the previous pregnancy, the woman delivered a baby that weighs less than 10 centile, and the baby was delivered less than 34 weeks. However, low molecular weight heparin has been shown not to be of use, except if there are other obstetric indications for its use. Some people have also tried sildenafil because of the fact that we know that it causes vasodilatation, but it has not been shown to be of significant benefit according to the Society for Maternal-Fetal Medicine, and sildenafil is not recommended as one of the antepartum intervention to prevent IUGR. So what happens with some other antenatal period? What are some other challenges that can come? IUGR plus congenital anomaly. Such women should be offered fetal diagnosis testing, chromosomal assay, as well as assessment of fetal malformation, regardless of the gestational age, so that we'll be able to categorize them appropriately. And then screening for toxoplasmosis, rubella, and herpes has been recommended in IUGR, especially in the absence of other risk factors, to be able to establish the cause of the IUGR. Now, in terms of management now, general overview is that the single most important prognostic factor in preterm fetuses with IUGR is the gestational age. So what we do in the management is that we want to maximize intrauterine stay, prolonged intrauterine stay before delivery, while we are avoid premature, while we guard against fetal mortality. In other words, there is no hurry in trying to deliver a fetus that show evidence of IUGR if there are no ominous signs, as we are going to see later. So what do we use to monitor? Generally, we do not have evidence to say this is what should be the frequency of monitoring. However, as we are going to see later, we'll see that different guidelines have explained to us the various recommendations which we can actually follow in assessing or monitoring these women. But suffice it to know that frequent anthropometric measurement, Doppler studies, CTG, and biophysical profile has been shown to be very important, useful tool, especially when we know that IUGR, more than 80% of IUGR fetuses show abnormal umbilical artery waveforms on Doppler. And that is what has given umbilical artery Doppler its central role. What should be the frequency is now individualized based on what we find in a particular fetus. Now, what are some of the trial reports? Well, there is a truffle trial, which is a trial of randomized umbilical and fetal flow in Europe, which recruited women at 26 to 32 weeks gestation with AC, abdominal circumference of less than 10 centile, and uterine artery pulsatility index greater than the 95th centile. And the intervention of interest then was delivery of the fetus according to protocol. What did they find out? Now, they show that outcome in terms of perinatal death was uncommon, and that 70% of the fetuses survived without severe neonatal morbidity. What this is trying to tell us is that if we have in place a good follow-up and monitoring protocol or policy, we do not need to rush to deliver IUGR fetuses, because perinatal death is not so common as one may imagine. And then we have the GRID study, which also looks at a longitudinal study also of IUGR babies, and they the outcome, the summary of their own finding is that delaying delivery of very preterm IUGR in the setting of uncertainty resulted in some stillbirths. Immediate delivery produced an almost equal number. As a result, there's insufficient evidence to support either immediate or delayed delivery. So what they are trying to say is that whether you choose to deliver immediately or you delay, it doesn't really give you any advantage. Therefore, further confirming the need for a standard protocol for management. And then we have the digital study. We talk about disproportionate intrauterine growth intervention trial at term. They randomly assigned 650 pregnant women over 36 weeks gestation with suspected IUGR to either induction of labor or expectant monitoring. And what this showed is that whether you choose immediate induction of labor or you monitor expectantly and deliver when it's indicated, there is really no significant difference, further corroborating the fact that we don't need to rush to deliver IUGR babies. Now, what are now some of the abnormalities that we may see? Now, what this figure is trying to show us is a pattern of abnormalities that is seen in IUGR. The upper one is for early onset IUGR, while the lower is for late onset IUGR. Important points. First is that abnormality starts for early IUGR, abnormality starts with the umbilical artery, followed by the middle cerebral artery, and then followed by the ductus venosus. Also important is that if you are looking at biophysical profile parameter that will be of use in monitoring, a declining amniotic fluid volume is much more relevant when we compare it to other parameters like loss of tone or loss of movement, because all those ones come later when significant injury will have happened to the fetus. For the late onset IUGR, the same pattern also suffices. Umbilical artery first before middle cerebral artery, but then it tells us that a non-reactive fetal heart rate is an earlier sign of ominous events. And that is where monitoring with cardiotopography then becomes very important, especially computerized CTG. Now, this diagram is showing the pattern of clinical progression in IUGR. And what we see here is that in the early part, yes, uterine artery pulsatility index increases, CPR reduces by less than 5th percentile, middle cerebral artery. But then by the time acute deterioration is setting in, it tells us that CTG is one of the very important things that can be assessing tools that can be used. However, it emphasizes that computerized CTG is better. And the reason is that computerized CTG is more objective compared to the regular CTG, where the individual has to manually interpret and assess the tracings. Now, this is for late IUGR. The first one is for early onset IUGR. For late onset IUGR, what are the important things, important findings? Important findings are that CTG deceleration is a late finding. So it cannot be relied upon to be what is going to be the main diagnostic criteria. And that is why if you look at, remember the earlier picture I showed earlier, they prioritize Doppler. And the CTG and biophysical profile will only come in when we have Doppler findings that are suggesting an acute deterioration. So we use CTG and biophysical profile to confirm, not to make the diagnosis in late onset IUGR. And this table is just trying to show us tests that can be used that can give us an idea of a long-term, medium-term, or short-term. And we can see that uterine artery Doppler studies give us a long-term benefit, valid for about 2 weeks. Medium-term will be uterine artery Doppler studies and amniotic fluid as well about physical profile, while non-stress tests as well as computerized CTG will come in as a short term. In other words, the findings or the result we get from them can only be used for monitoring for a short period of time. Now, what are some recommendations that have been made? Now, the Society of Obstetrics and Gynecologists of Canada recommends that management of IUGR should be based on timing. Now, why this is important is that different people what should we base our monitoring of antepartum management on? Should we base it on timing, that is early versus late? Should we base it on risk factor, as in low, medium, or high risk? Or should we base it on fetal biometry in terms of whether type 1, type 2, or type 3? I'm going to show us some of the monitoring schedule later. But for Society of Obstetrics and Gynecology of Canada talks about the fact that it should be based on timing. In other words, early versus late. Now, for the Royal College of Physicians of Northern Ireland, now they talk about the fact that it should be based on the Doppler findings, especially omnial signs like absent end-diastolic flow or reverse end-diastolic flow in the uterine artery Doppler velocimetry. But for them, they said that this should be corroborated with a CTG finding. Now, this is the recommendation of the RCOG in the management of early IUGR. They recommend that pregnancies with early IUGR should be managed in a tertiary health facility with a good neonatal support. They emphasize the importance of multidisciplinary management involving the obstetrician, the neonatologist, and the radiologist, and that multimodal assessment should be used. And what should be in that multimodal assessment should be a computerized CTG, umbilical artery, middle cerebral artery, and ductus venosus Doppler. And that when computerized CTGs are available, the critical finding there should be the short time variation. It should be the main parameter that should be assessed. Now, I want to now show us some of the guidelines or recommendations that we've had from different sources. Now, this one is talking about how do we manage a fetus with late IUGR. As has been said, that is the definition. We have talked about that before. Now, it says that when we have fetuses with late IUGR, we should then find out, do we have evidence of placenta dysfunction or not? And that if you have a fetus with late IUGR that is occurring after 32 weeks with evidence of placenta dysfunction, except you have findings that indicate immediate delivery, we should not deliver them between 32 to 37 weeks. In other words, they do not merit early delivery. That's the summary. Secondly, they also say that in suspected fetal growth restriction without evidence of placenta dysfunction, timing of delivery should be between 37 to 37 weeks plus 6 days, and that this decision should be taken by a senior obstetrician. Then they talk about SGA or IUGR fetuses between 3rd to 10th centile without evidence of placenta dysfunction or other concern should be delivered between 39 to 39 plus 6 weeks. And this is what they are recommending. And that in time IUGR with normal umbilical artery Doppler, which is not uncommon in late IUGR, an abnormal middle cerebral artery Doppler has a moderate predictive value for acidosis at birth, and that can be used to plan our delivery for late IUGR. Now, this is another one from and I think this one is from the NHS. Now, this particular one look at, you start with a clinical suspicion. We use our risk factors, and then there's a suspicion. Then we go for sonographic assessment. And with that sonographic assessment, we then find out, if the fetus is more than 10 centimeters, it follows routine pathway. If it is less than 10 centile, then we don't need to confirm our dating, and then that we should consider a customized centile for assessment, and then we should do a full anatomic scan to rule out congenital abnormality. So if there is a normal umbilical artery Doppler, what should be done? We can repeat the Doppler at 2-week intervals. And when we are doing that, we are assessing biometry, uterine artery, and amniotic fluid index. And if these do not show any evidence of deterioration, we can consider delivering at 37 weeks, but not later than 40 weeks. But if we have abnormal uterine artery Doppler, that is, pulsatility index is greater than 95th centile, and there's abnormality of end diastolic flow, the sonogram should be repeated more closely, that is weekly, or unless if indicated. Then we should now do 2 weekly biometry assessment to see whether the fetus is gaining weight. By the time the fetus is getting to around 32 to 33 weeks, we should give corticosteroid, and we should consider delivery at 37 weeks or earlier. What this is saying in essence is that umbilical artery Doppler can be used as a tool in determining when we want to deliver. If it's normal, you deliver between 37 to 40 weeks. If it is showing abnormality with increased pulsatility index, you deliver at 37 weeks. If the umbilical artery Doppler is showing absent end diastolic flow, then you should deliver before 34 weeks, usually between 32 and 34 weeks. And you should give magnesium sulfate for neuroprotection. But that if there is reverse end diastolic flow, then we should deliver not later than 30 weeks, because reverse end diastolic flow is a worse prognostic indicator compared to absent end diastolic flow. And so this is what shows us what happens when we are using the umbilical artery Doppler as our main tool for the monitoring. This is another one that is looking at management based on the categorization based on anthropometric factors, symmetric or asymmetric. But one of the things we will notice here is the fact that this one is recommended growth scan every 3 weeks. And the reason is because we're actually using anthropometric diameter and parameters. So what that also means is that frequency of monitoring of fetuses with IUGR will actually depend on whatever it is that we are using for monitoring. But for this kind of fetuses, delivery should be considered at least 32 weeks. So they should not be delivered less than 32 weeks of gestation. Now, this is from Society for Maternal-Fetal Medicine, but also validated by RCOG. And this one gives us a panoramic view from when we assess the woman. It's based on risk assessment, actually. Moderate, low, or high risk. And then how we move on from there until the woman delivers. But suffice it to say that even when we are using the risk assessments as our criteria for the monitoring, Doppler velocimetry still play a very important role in planning delivery. This is also showing the same thing, telling us that omnial signs are absent end diastolic flow or reverse end diastolic flow, and that we should be watching for also abnormalities on computerized CTG to look for evidences of acidosis so that we can then plan delivery. This is a truffle study flow for management of SGA and by extension IUGR, but it seems to agree, not much difference with the ones that we have seen previously, except that in assessing for delivery, they prioritize computerized CTG, umbilical artery Doppler, and maternal indications. Then there is the stage-based management. that looks at, is the woman stage 1, stage 2, stage 3, or stage 4, based on all these correlates. The important thing to note here is that as the stage increases from 1 to 4, the mode of delivery and the time of delivery changes. For stage 1, 37 weeks. For stage 2, where we have severe placenta insufficiency, 34 weeks is the cutoff, and it should be by cesarean section. And then we have stage 3 and stage 4. This one is showing us the management based on gestational age and Doppler ultrasonography. Not too different from the ones we have discussed earlier for the sake of time, but it also prioritizes uterine artery and middle cerebral Doppler velocimetry. Now, there are those that now manage women based on risk categorization. But the problem with risk categorization is that many of the parameters that you need to categorize the women may actually not be available. So, in clients like ours, where we do not have enough information on the previous pregnancy of the woman, it may be advisable that we should not prioritize management based on risk categorization. Moderate risk and those at high risk. I've explained this before. We've talked about this also. Now, let's now look at delivery. These are the recommendations. These recommendations are from the ISUOG. The ISUOG. And they said that whereas 24 to 25 plus 6 days personalized management, but that when we get to greater than or equal to 34 weeks, we should deliver if umbilical artery shows end-diastolic flow to be absent, or XTV is less than 4.5, and that corticosteroid should be given. An elective cesarean section is recommended if one of the following is present. In other words, cesarean section, IUGR is not an absolute indication for cesarean section. If you have abnormal computerized CTG, we have, in terms of the short-time variation of the fetal heart rate, ductal venosus abnormality, or absent or reversed uterine artery end-diastolic flow. Still on the same thing. What this is trying to tell us is the importance of magnesium sulfate, and that it should be given targeting at least 4 hours prior to delivery for it to be able to achieve maximum effects. And that when we do this, it's been shown to reduce the incidence of cerebral palsy, especially in high-risk preterm infants, according to the RCOG. Now, what about postnatal care? After delivery, the problem of IUGR has not stopped. The challenges still continue. And the recommendation is that when a woman has delivered, the neonatologist should assess the baby and get the individual birth weight center and calculate it for the baby, whether it's a live born or a stillborn. The importance of this is that the woman will need this in a subsequent pregnancy. And that if any baby is born with birth weight less than 3rd center, the placenta should be sent for histopathological examination. And that at the postnatal visit, all women who deliver IUGR babies must have a specific postnatal visit, where we discuss identifiable risk factor in the pregnancy. We look at the results of the placenta histopathological evaluation, and then we can then screen the woman for other risk factors like inherited thrombophilias. And it is at that same sitting we should then start assessing the risk of recurrence and pregnancy outcome for subsequent pregnancies. And the specific testing for antiphospholipid antibodies, when clinically indicated in these women, should be limited to lupus anticoagulants, anticardiolipin, and anticardiolipin antibodies, and beta-2 glycoprotein antibodies. In other words, it is not for everybody. We should actually screen the women to see if they are at risk for such assessments. Now, this is on perinatal. After Antepartum, the fetus is at risk all the way through. Antepartum, intrapartum, at birth, they have all kinds of problems: hypothermia, hypoglycemia, polycythemia, sepsis, coagulopathy. And then after birth, they are at increased risk of long-term consequences: short stature, cerebral palsy, developmental delay, low IQ score, as well as cardiovascular diseases even in adulthood, especially hypertension. So, what are now the issues concerning prevention and prognostication? Now, a lot of work has been done on this also, but we are just going to look at important things. A systematic review by HEDA reported that multivitamins, administration of multivitamins to women both prenatally and in the antenatal period, gives better outcome than one or two nutrients that we normally use in terms of iron and folic acid. While Kramer et al. In the systematic review of experimental research reported that there is a reduction in SGA neonates and by extension IUGR if the mother takes care of, we will take care of a protein intake in the woman, talking about the nutritional aspect in pregnant women. That nutrition, so the summary is that nutrition is, now modification is also important. Then Velota et al. In a meta-analysis reported that uterine artery Doppler in the first trimester can actually have a prediction rate of 15.4% for IUGR, while Crovetto et al. In their own reported that Doppler can also be used in detecting both early and IUGR with a rate of 86.4% for early and 65.8% for late IUGR. Screening for maternal characteristics also has been shown to be very useful. So also, mosquito issue around malaria prevention has been found to be useful. And then a meta-analysis of 45 randomized trials showed that low-dose aspirin for the prevention of eclampsia and IUGR in women is beneficial compared to women who receive placebo or no treatment at all. Anticoagulant, especially low molecular weight heparin or unfractionated heparin, has been shown not to be beneficial. The Society of Obstetrics and Gynecology of Canada and RCOG advocate that women should cease smoking in subsequent pregnancy. Beta mimetics has not been shown to prevent IUGR. Vegani et al. Use umbilical artery pulsatility index and abdominal circumference center that it can be used to predict adverse neonatal outcome with a sensitivity of 75% with a false positive rate of 18%, meaning that these two can actually be of importance, as it's been highlighted earlier. Again, the Laster et al. Shows that when we are assessing for composite adverse perinatal outcome, the mean uterine artery pulsatility index is very, very important and can be useful in predicting intrapartum distress that can lead to obstetric intervention in these women. Others have talked about markers in second trimester, especially placenta growth factor that has been used, is being useful, especially in babies that have less than third centile and were born 30 weeks. Serum placenta growth factor has been found to be useful in predicting this kind of outcome in women. Rizzolo et al. They try to use a fetal-placenta Doppler to see whether a multiparametric diagnostic model can be useful. And what they found out is that only the umbilical vein blood flow over abdominal circumference ratio showed moderate accuracy in predicting CAPO, that is composite adverse perinatal outcome, while the diagnostic performance of cerebroplacental ratio and uterine artery pulsatility index was reported to be low in them in their own study. But it is important to know that their study was actually in women who have late onset IUGR. So will this be useful in early onset IUGR? Is still subject to further assessment and evaluation. And this was a study done in Nigeria. It was done in Jos, Nigeria. And what they tried to, why I brought this up is that it actually confirms the fact that the greater than 95% pulsatility index in the umbilical artery Doppler is actually useful even in our own population, because it was able to predict all the 10 perinatal deaths that occur in their study, and the study was done in Nigeria. So it can actually be something to take very seriously. Now, what are the considerations for future research? One of the important things with IUGR is that for now, we don't have a composite multi-parameter screening and assessment modality, and that is very, very important. So we need to work on that. Secondly is, when should the first ultrasound be? And what should be the predictive accuracy of these different methods, especially in our own environment? And then the issue of biomarkers. They have been showing, yes, they've been showing evidence that, yes, future use or current use in some places, but should it be universal screening? What about the costs and things like that? And then, which reference chart should we even use? While there are some new formula coming up, most studies still stay with the old HADLOC, which is a population base, but others are talking about the fact that why not use a customized growth chart for the fetus? This we also need to work on. And then the issue of, if a woman has multiple risk factors, how does that affect her risk? And then, is it beneficial to deliver fetuses with late IUGR and signs of cerebral fall distribution? That is, by removing them from the hostile environment, or is it actually harmful? We've not really have enough evidence on what to do concerning that also. Now, while I was preparing this presentation, my original intention was to be able to come out with a suggestion on what we can follow to be like a guide. But then I found out that that became impossible for me at the end of the day, because there are some questions that we will need to look at if we are looking at a national guideline. And I put this so that it will be food for thought for those who might be, because I know that our association will be interested in developing something like that for our country. What are the main issues? Patient factors. When do we want to start monitoring? We've had a recommendation of, yes, 14 weeks, but then we need to consider what is the gestational age that our women book in this environment. We know our women don't book early. Secondly, this serial Doppler that is used for monitoring, what's the level of access for those who need it, before we will include such in a guideline, or it will also affect the strength or the weight that we will put on it. What about the healthcare provider? We need to have a uniform diagnostic criteria. And then secondly, we need to decide which pathway of management do we want to follow. As we have seen, there is the risk-based, there is the early versus late, timing, or symmetric, asymmetric. Which one do we think will be best for our country, Nigeria? And all of that will depend on some of the factors I highlighted earlier. Because if we are picking most of our patients late, then using the early-late protocol may not be the best option for us. And then we need to develop our association. We need to work on a policy to guide us. Then responsibilities. We need to apportion responsibility. Who does what in this management? And then when should we refer? Facility factors. The challenges of Doppler ultrasound in most of our facilities. And then when we now discover that, when we put that side by side with the fact that we now need a serial Doppler, manpower, equipment that will be needed, and then the health system itself. Biochemical screening has been shown to show some evidence. How strong is our health system to support that? And then secondly, who bears the cost? Antenatal, postpartum, and especially newborn care. A few days ago, we were discussing, and that's when I discovered that somebody brought it to our attention that even if health-insured women, some HMOs don't automatically put the newborn into the plan immediately after birth. So what happens to the postpartum care for the newborn, which we know is also critical? These are some of the things that we need to come up with so that it can form part of recommendation for our health system, and it can help us to get a national guideline that can be useful in our country, Nigeria. So these are the reasons why I was not actually able to come out with that, because decisions on all of these factors is not what a single individual can actually take. And our association will need to possibly get a committee to work on that for us to assess and come up with the guideline. So what are some of the take-home points? We know that globally, IUGR remains a problem. It is not uncommon. It is here with us also. That early identification and appropriate prenatal monitoring reduces the likelihood of adverse outcome. And that the management or monitoring tools have been earlier pointed out. Now, the management of IUGR is multidisciplinary. So we should always activate that part of us whenever we have a fetus that we are suspecting IUGR. That we don't need to rush, and that's the key point. When you have an IUGR fetus, you don't need to rush to deliver. With adequate and effective monitoring, we can prolong their stay in utero, thereby improving their survival extrauterine. And that we need to also know that undiagnosed IUGR is one of the worst clinical scenario that a fetus can have, because it has been found that it increases rate of stillbirth by 5%, and it further makes the problem in such fetuses to be more permanent and irreversible than the others. That choosing time of delivery depends on a number of parameters that will be of help, as highlighted, and that as obstetrician, we need to actually come up with a guideline that can help, especially in our country, Nigeria, based on our own peculiarities. I want to thank you very much for listening, and these are the references. Thank you very much.
Thank you, Professor Adeniran. We very much expected this comprehensive presentation, and he has taken us through all aspects of IUGR, including the latest or recent advances in the management of IUGR. And also he has discussed a bit about our own local context. What can we do? Do we have the capacity in terms of manpower and equipment? Do we also have patients who will come at the right time for the screening and so on? So I think this is a very comprehensive presentation, and we have all heard him. I'm sure there are some questions, and even though we have spent most of the time already, but I feel we can give one or two chances for people to ask questions. So if there are questions, somebody can ask. Any question?
Yes, sir. There are questions displayed in the chat box.
Okay, in the chat box.
Yes, and it's displayed on the screen.
So, yes. So I am seeing the chat box. And
the question is projected on the screen. I don't know if you can
projected?
see it. Yes, on the screen.
Okay, this is from the chat box.
Yes, sir.
So I feel maybe Prof can read the question and then answer.
Okay, thank you very much.
Can you project it so that you can see?
So that it makes it faster. Thank you very much. Now, this question says, please comment on why radiologists don't report the percentile of an estimated fetal weight, even when you indicate the clinical notes as suspected IUGR. They just give you the estimated fetal weight. Yes. Now, that may not be unconnected with the fact that, number one, what is their own definition of IUGR? And just as we have been said, as I've highlighted, it is not acceptable to use estimated fetal weight alone when you are monitoring or when you are assessing a fetus with IUGR. So it might be because, one, they are using a different definition from us, or it might actually be that maybe the person who is doing it does not understand the importance, or maybe does not know how to do it. So I think that we need to, I will recommend at this time, we need to relate with them and let them know that actually this is what I want. This is what I want. And I think that that will help us. Thank you. Another one says, any customized charts for Nigerian or African fetuses? If not, which one is recommended for Nigerian setting? Actually, people have been working trying to get a customized chart, but most times when people do estimated fetal weight for us, most people use the hard lock, because most people are used to it. Universally, it's been shown to be useful in practically all settings, and many studies have shown that it's actually associated with a better predictive factor. Now, whether there are charts for Nigerian or African fetuses, I am not too sure, but I know that most people use the hard lock for their estimation of the fetal weight when we send patients for them. This one, this is from Dr. Danjuma from Taraba. Okay. In deciding to deliver, do you only consider the gestational age, or is there a need to also consider fetal weight? Just as I've stated earlier, there are criteria for delivery. In delivering, you are not using only the gestational age. It's a composite factor. The first thing we need to note is that in IUGR fetuses, there is no need to rush delivery, except if there are ominous signs. An ominous sign will be either an absent or either an absence or reverse flow in the umbilical artery, or if you do a computerized CTG that gives you an abnormality in the ST fetal heart rate variability. Now, if that is not there, you need a combination of the gestational age. You need a combination of the general status of the fetus, umbilical artery, Doppler, all of that. Then you also need a combination of CTG that will tell you that is there acidosis now or not. If all of that are not there, then you just refer to the respective charts that I've shown earlier on the gestational age. So it's not only on the gestational age. There are other factors that need to be considered. Dr. Katagum, next one. Hello, Prof. Is there more correlation between maternal daily positioning and the growth restriction outcome of the baby as it comes to the vascular supply, both the anatomical? Well, this has not been validated. I think the simple answer is that this has not been validated, and I'm not aware of any study that have tried to correlate the two. But if you look at what we have been, what I've explained, you will see that this is not likely to be something that will give a statistically significant improvement, because there is a placental pathology. And by the way, for how long is the woman going to lie down in a whole day? So I think that that will take care of that, that we do not have studies that looked at that one for now.
Thank you, Professor Adeniro. I think we have spent a lot of time, and it's getting late. We have spent more than the usual time we allot to our seminars, our webinars, sorry. So, and I think I will have to mention two things, especially on the upcoming AGM. The AGM is coming in July, between the 8th and the 9th of July this year, and it is going to be a virtual AGM. And that we are still accepting abstracts. The abstracts deadline has been extended to the 9th to the 19th of June. So there is still a lot of time for those who have plans to submit abstract to do so before the 19th. Today is 17th, so the time is very limited. However, you can still attempt to submit your abstract for the upcoming AGM, which I said already is a virtual AGM. And personally, this webinar has stimulated a lot of interest in me, and I have been doing some work, for example, talking about customized growth chart for our local population. And then also in terms of screening, not necessarily screening for IUGR, but screening for preeclampsia, which is also a cause for IUGR. And my own approach is what I call a two-stage approach, whereby you use some risk factors at the primary healthcare level, and then if you identify a cohort of women who are at risk, you can now refer them to the tertiary center for further evaluation, which we cannot do in the primary or secondary facilities. So this is a very interesting presentation by Professor Adeniran, and I want to thank him very much for this wonderful presentation. And I know the president is waiting to say one or two words before we close. Mr. President.
Yes, good evening, ladies and gentlemen, members of AFEMSON. I want to say that what happened today is one of the functions of AFEMSON, which is capacity building, and capacity building on subjects that are relevant for reduction of maternal and fetal morbidity and mortality. And I think this has been well taken care of by my good friend, Professor Abiodun Adeniran, who everybody can testify is well grounded on this subject and has delivered the subject very well in a simple way, all aimed at improving our various practices and with the overall aim of improving the currently abysmal statistics that we have for Nigeria. So I want to thank you so much, Prof. We really appreciate you. And please, when we knock on other members of AFEMSON to come and present, please want something like this so that we'll all benefit from each other. So thank you so much. I really appreciate, and we look forward to hosting our members and non-members or people who want to join AFEMSON. There were slides on how to join. I believe, I know that all our presentations are also on our social media handles. And we look forward to seeing you at our annual general meeting in less than a month's time. Thank you very much, Educational Committee, for this. We really thank you, and we look forward to more of such presentations. Thank you, and good night for everybody. Yes, Dr. Prof. Aliu, over. You can close the meeting, please.
Okay. So just to emphasize the importance of the upcoming AGM, I mentioned that it is virtual, and it is going to be between the 8th and the 9th of July. So please, I urge people to register and participate. Presentations like this are likely going to be available during the AGM. So I urge everybody to join us at the AGM and to register before the closing date of the registration, even though you can register on site, but it's better because the cost is much less than when you register on site. So thank you very much. We hope to have the next webinar announced, and you should be watching or going to our website for information on AFEMSON generally, the way to join it, the benefits of joining it, and other important information. Somebody has asked in the chat box that will the slide be shared? Yes, definitely. My friend, Dr. Umaru, was the one asking for this. And I assure him that the slide will be available at our website. So thank you, everybody, and good night. Thank you very much.
Good night. Thank you, Prof. Abiodun Adeniran.
Thank you, sir. My Oga, my provost. Thank you, President.
My good friend.
My president, thank you.
Well delivered. Thank you so much. We appreciate it.
Okay, sir. Thank you, sir. It's a pleasure, sir. Thanks for the opportunity. Bye. Yeah.